Thank you so much for attending this year's keynote speech on Visiting Scholar Day, hosted by UNC's Department of Health Policy and Management. I'm Addie Coleman, a PhD candidate in HPM, and I'm honored to introduce today's keynote speaker, Mr. Daniel Dawes. Daniel E. Dawes J.D. is a widely respected healthcare and public health leader, health policy expert, educator, and researcher who serves as the Senior Vice President of Global Health Equity and the Executive Director of the Institute of Global Health Equity at Meharry Medical College. He's the author of 2 groundbreaking health policy books, 150 Years of Obamacare and The Political Determinants of Health, both published by Johns Hopkins University Press. Among his many achievements, he was an instrumental figure in developing and negotiating the Mental Health Parity Act, the Genetic Information Non-Discrimination Act, the Americans with Disabilities Act Amendments Act, and the Affordable Care Act's health equity-focused provisions. He serves as an advisor to the White House COVID-19 Health Equity Task Force, an appointed member of the CDC's Advisory Committee to the Director, where he co-chairs the CDC's health equity work, and the NIH's National Advisory Council for Nursing Research. Fun fact, he's a product of Nebraska. The title of Mr. Dawes' keynote lecture today is The Political Determinants of Health. So please give a warm welcome to Mr. Daniel Dawes.
Hello, everyone. Hello, it's so good to see you guys again. And thank you so much, Addie, for the very kind introduction. Let me tell you, I am excited to be here. I'm glad you all could accommodate me, as I mentioned to Addie earlier, into your schedule. And I apologize that I couldn't be here last week. You know, there's a little thing called climate change that has significant impacts on travel nowadays. To the chair of the department, Justin Trogdon, I appreciate the invitation. And of course, to Valerie Hooker, who made sure that we were able to make this happen a second time. So with that said, really excited to get into how we can move beyond nibbling at the edges of the problems of health inequities in our society and how we can effectively repair the past. So, you know, the former youth poet laureate, Amanda Gorman, during her inaugural poem, mentioned in her poem that being American is more than the pride we inherit. It's the past we stepped into and how we repair it. So I'm going to talk today about how we can really achieve health equity in the United States by addressing and leveraging the political determinants of health. You know, as I think about this period that we're in, it reminds me of what Ken Burns, the documentarian, has been saying. Any Ken Burns fans? Yes? All right, good. So, you know, Ken Burns has basically been stating that he believes that we're in the 4th great crisis in US history. And he talks about how this has really been fueled by a 100-year pandemic, this 404-year-old syndemic perpetuated by racism, and of course, the age-old epidemic of conspiracies and misinformation and so forth. So I want to talk about how we can overcome all of that in the time period that we're in, especially today. So let's begin. So just let these statistics wash over you for a moment, right? These under-resourced groups are folks who have struggled to live in our society that has intentionally erected barrier after barrier to weaken their bodies and hasten their deaths, leading to the striking inequities that we see across the lifespan in health status and in healthcare and in longevity. Now, interestingly enough, we know that studies have been done. David Satcher, who's my dear friend and mentor, did one looking at a 10-year period. And he found that during that time, with all the technological advancements that we had made, about 176,000 premature deaths were prevented. But he said if we had taken an equity lens to that work, almost 1 million lives, African-American lives, would have been saved. And we didn't even have the numbers for the other groups, right? When you boil that down, we're talking about 83,000 African-Americans dying prematurely. We don't even have the numbers for people with disabilities, for LGBTQ individuals, for Latinos, and other groups. So something to think about. As we think about the lives lost, as we think about the health impact, one of the things that we also have been looking at, because we recognize that in order to advance health equity, it usually has to be aligned with a governmental interest, and it has to be palatable to the commercial interest, right? And as we were working on the Affordable Care Act, as we were making the moral argument that people are dying prematurely, it was fascinating how quickly strategy shifted. And the White House said, well, yeah, we get it. It bleeds our heart that people are dying prematurely, but you have to show cost savings. You have to show how advancing these health equity focus provisions in the law will actually help to save money in the long run. So thankfully, we had Daryl Gaskin, Tom Leviste, who were at Johns Hopkins and George Washington University at the time. They did this study looking at the costs of unequal treatment and basically disparities in health status. And they found that in 2009, we had spent conservatively $300 billion on the majority of chronic diseases, owing again to the disparities, racial and ethnic disparities. Now, fast forward to the present. Last year, Deloitte did a study, and they only looked at the top 5 costly diseases in the country. And what they found was that the disparities, the economic burden of disparities owing to those 5 diseases, asthma, breast cancer, prostate cancer, heart disease, you name it, right? That now the cost was $320 billion. Think about that. We're going from $300 billion, 2009, with a majority of chronic diseases, does not include mental illnesses, to 2022, $320 billion. And what they also projected was that by 2040, we were expected to increase that amount to $1 trillion per year. Think about that. So as the country becomes more racially diverse, as they are coming from communities that are sicker and dying prematurely, we expect that to increase significantly if we don't tackle the issue of health disparities today. Now, I think we've all seen the recent headlines really highlighting the everyday impact of the political determinants of health. We have seen over the last 3 years the struggle to advance health equity in America, the levers of public policy that have been pushed and pulled at all levels of government, quite frankly, to either advance or hinder health equity. I think we all know, as we think about the period of time, you heard me mention Ken Burns talking about the 4th great crisis. He talks about the four periods of crises in American history. I actually, from a health equity lens, though, think about it differently. I believe that we're in the 4th period of a great awakening for health equity. The first period started with Abraham Lincoln, when he had initiated America's first major and comprehensive health policy to address the social determinants of health that were impacting newly freed Black people, as well as poor whites who had been impacted by the Civil War. That was interesting, right? Because it lasted 7 years, and then you saw opponents coming in and dismantling the program. It would take almost 100 years later, during the civil rights movement, 2 years into that movement, for health equity champions, very much like yourselves, to say, wait a second, Dr. King is right. Of all the forms of inequality in our society, injustice in healthcare is the most shocking and inhuman. What are we going to do about it? And so they went about creating Medicare and Medicaid legislation, pushing for the Civil Rights Act, the Voting Rights Act, Fair Housing Act, and so forth. And they really focused on addressing the overt forms of discrimination in healthcare and public health. Well, a few years after that, folks said, gosh, we tackle these issues, and yet we still see striking disparities among population groups. What is going on? So then there was another effort to address the more subtle forms of discrimination in our society, looking at minority health and health disparities, and then widening that to look at socioeconomic status disparities and so forth. So that brought us all the way to the Obama administration when we were working on the Affordable Care Act, which really is the most comprehensive and reticulated statute dealing with these health disparities. But it didn't go far enough, right? Because at the time, there was this concern about moving beyond these payment and delivery system reforms, beyond insurance reforms, as the social determinants of health were gaining steam, as the World Health Organization had actually published its report in 2008. That was around the time we're working with the Obama administration, right? Of course, the campaign first, then the administration in 2009. And it was such a novel idea for many folks in DC who were working on the Affordable Care Act that they didn't want to take those provisions in. They thought it would absolutely bring down the health reform bill, and people would say, this is a socialistic agenda you're pushing. What are social determinants of health? We have no idea what that means. So now fast forward, In 2020, we now have another election, right? And in this election, you have two really competing ideas about how to run the country and the direction that we want to take the country. In this case, we obviously know how that ended up. We have a federal government now that has completely committed to centering equity to a degree that we have never seen before. And not only, centering health equity, but moving further upstream to tackling the root causes of these inequities, something we have never before seen at the federal level, not even under President Lincoln with his efforts. So, all told, we know how these determinants collectively impact. And we try to figure out what is it, though, that really drives these inequities. We've heard from poverty to food deserts to redlining, slavery, gerrymandering, lack of green and blue spaces, employment. We've all heard what these social determinants of health, but what really has been driving these determinants that disproportionately negatively affect or benefit one group versus another? Well, we all know that racial and ethnic minorities, people with disabilities, lower socioeconomic status individuals, LGBTQ plus individuals, and people living in rural communities across the country are dying disproportionately each year. And of course, the toll that it takes is unconscionable, right? But the one thing that we should never forget as public health scholars and leaders is that the nation's health is not an organic outcome. It is not an accident that this is happening. And so let's talk about why it's not a coincidence, right? Why is this happening? Well, today, of course, we recognize that there are a variety of forces collectively working to determine the quality and the extent of our lives on this earth. And of course, key among these determinants, it is argued, are the social determinants of health, these structural conditions in which all of us are born into, we live in and we die in, that affect all aspects of life and well-being. And of course, they do play an outsized role in these human-made pre-existing inequities. But underlying every single one of these is a political determinant that we can no longer ignore, right? So as we think about this, too often we've been stopping at the social drivers of inequities, failing to look back and dig a little bit deeper to figure out the connections to these social drivers and their policy roots. Because you see, for every social determinant of health, there was a preceding policy, a law, case law, statute, ordinance at the local level, right? That created the structural conditions that affect all aspects of our health and well-being. So I wanted to illustrate this idea with this story. And I want us to envision, I'm not quite, what's the closest river to us? It's a really cool river. What's that? Eno. Okay, let's put on our creative hats for a moment, right? We're going to take a field trip to the Eno River. And I want you to think about this, right? Think about all of society sitting on the banks of that river, fishing and finding nourishment in what the river provides. The health inequities that we face are represented by the differences in the caliber and the quantity of fish we encounter. Some people have a bounty of healthy fish and vegetation to feed off of, while others may only have small fish or no vegetation, or malnourished fish. Different people having access to different types of resources and different parts of the river represents the social determinants of health. Now, some people are located in a slower moving part of the river by no fault of their own, while others are located in more lush parts of the river and benefit because of such, right? By specific decisions made on their behalf. Somewhere upstream, decisions were made to divert the river to benefit certain people and harm others. And decisions were made to place certain people on certain parts of the river while placing others elsewhere. These upstream decisions absolutely have significant downstream effects, as we all know. And I think over the last 3 years, what this endemic, quite frankly, has demonstrated is the inconvenient and harsh truth about the political determinants of health. Because I think what it also shows is that there's a compounding effect to political determinants over personal responsibility. I've heard many folks say, well, Daniel, people need to be eating better. They need to exercise better. They make assumptions about people's limited choices. And no matter how much many marginalized and vulnerable population groups in our society try to act responsibly, there are always these structural, institutional, and even interpersonal and intrapersonal obstacles that have been hindering them, right? And I think beneath these communities' notice are political determinants that have pulled and continue to pull strings that prevent them from achieving their full health potential. So let's get down into this, right? Why did this happen? How did we get here? How is it that inequality gets under our skin, leading to accelerated aging in our bodies, as Dr. Arlene Geronimus at the University of Michigan has coined? How is it that it leads to the earlier onset of chronic diseases in our bodies over time? As David Williams and others, of course, Dr. Peggy has studied and reported on. It's amazing. Well, let's talk about that. Let's talk about how inequality gets on our skin. And we all know that, at the root of this, right, the impact of slavery has been associated with contemporary mortality and poverty, heart disease, trauma, maternal and infant mortality, you name it. And so as we think about the structural conditions, as we think about our neighborhoods, as we think about resources, as we think about why they are the way they are today, we need to be thinking about what instigated those conditions in the first place. And so I want to take us back to 1641. I do believe 1619 is a fair starting point, but I'm going to start at 1641 because this is when the commercial interest in the policymakers who wanted to sustain the model of slavery recognized that the abolitionists were gaining headway, right? They're gaining some steam in their movement to abolish that evil institution. And they said, we need to create a law and legalize this before they actually convince the majority of folks to do the opposite. And so they immediately went on working on a bill called the Body of Liberties Law, a law that was then, after pushback, passed not only in Massachusetts, but then in Maryland, New York, Connecticut, and the other colonies. The abolitionists, the health equity champions at the time said, wait a second, we believe when you read that law that it actually never intended to include the offspring of these Black enslaved individuals. And so they went about fighting that interpretation. Guess what happens? As we see in this movement to advance health equity, what happens? They move the goalposts, right? All the time. And so that's again what happened. They amended the Body of Liberties Law to include the offspring, to ensure that the descendants of these enslaved individuals would forever be in that terrible cycle of slavery. Well, as if that weren't enough, what else do? They went about creating additional policies that prohibited Black and Indigenous folks from being able to raise their own food. We know food is a critical social determinant of health, right? They were forbidden by law from being able to earn their own money. Another critical social determinant of health, right? Employment opportunities and so forth. Well, they also went beyond that, denying them the ability to be educated. We know education is another major social determinant of health. And we also saw laws being developed, negotiated, and passed, and implemented, and enforced that would limit movement for Black and Indigenous groups in the country. So essentially, stating that depending on the jurisdiction, if you were on a certain or a certain plantation, you couldn't go beyond a 1 mile radius. If you were moving at nighttime, you had to have a lantern. If you wanted to move beyond that 1 mile radius, you had to have a pass in order to do so by policy, right? And again, we know movement is so key to life. So you can see how policy has been used to basically limit the choices, limit the opportunities for certain segments of our population. Now, those laws, those policies were then recycled from one generation to the next, from one century into the next, into the 1700s, then into the 1800s, where Jim Crow reared its ugly head with a vengeance. And here we saw the proliferation of policies and laws, right, at all levels, local, state, federal, again, designed, these racist, these explicitly racist policies designed to forbid folks from being able to address their social determinants of health needs. And what else do we see? We're moving into the 1900s now. And as the abolitionists, as the health equity champions were fighting to say, wait a second, these explicitly racist policies are unconstitutional. They're a violation of our Equal Protection Clause. The Supreme Court could no longer deny that truth, right? There was a concerted effort to say, no, we're not putting up with this anymore. This is foolishness. And finally, they succeed in getting the courts to agree, right, and overturn these explicitly racist laws, these exclusionary laws that had denied certain groups the benefits of our social and economic policies. But what happens? In the early 1900s, we then see an effort to develop what we call in the law facially neutral policies, right? So on their face, they don't leave out a certain group or prohibit a certain group from benefiting from the policies, but they're designed in such a way that when they're implemented, they have the same effect. Social Security Act was one of those. It was designed by Perrin, Dr. Perrin, who was the Surgeon General at the time, a master architect of the syphilis study in Tuskegee, one of the most racist public health leaders in our nation's history. And he intentionally worked with Congress to create the Social Security Act to deny the benefits to people who were domestic or agricultural workers, at the time, largely African-American and immigrant groups. Interesting, right? 80% of African-Americans at the time fell into one of those two buckets. They were not able to benefit early on, right? In addition to that, we're going through World War I. We went through it. And the Franklin D. Roosevelt, again, is working on different bills, the New Deal. They're working on all these policies, which didn't positively impact many African Americans. One is the Homeowners Loan Corporation Act that, quite frankly, had the opposite effect. A law that essentially authorized property appraisers to go out into the cities, into the neighborhoods of these cities, 200 cities, and to color code them and grade them accordingly. Your A communities were your green communities, your B communities were your blue communities, your C communities were your yellow communities, and your D were your red communities. Your A communities were your affluent white communities. Your B communities were your middle-class white communities. Your C communities were your quote-unquote undesirable immigrant communities. And these were at the time largely Mexican, Cuban, Irish, German, Jewish, Italian communities. And then we get into the red communities. These were classified as hazardous communities. And these were primarily African-American communities. What's very interesting about this episode was that once the reports were done, they were aggregated, they were then sent back to Washington, to DC, where the federal government used it to create additional policies that determined who in these neighborhoods were quote unquote deserving, right, of these investments from the federal government for VA and FHA home mortgage loans. Well, as if these communities hadn't already for generations been starved of the resources that they need not only to survive, but thrive in society, they were further starved of resources with these policy determinations. And we know today, I know you all know this in our conversations, we talked about the health implications that they have had over time. We know that because of these policies and more, there's a direct link to aggressive breast cancer prevalence in African-American women who have triple negative breast cancer, right? The most deadly form of breast cancer owing to the isms in our society. We know then afterwards, after World War II, there was another attempt at pushing and stimulating our economy and creating, again, facially neutral policies that had a terrible health impact. So as we think about the communities that we're working in or we live in, that you may have been, you have grown up in and so forth, it's been very interesting as I travel the country and I meet with folks all over and I say, how did that highway get into your community? How is it that it's splitting your neighborhood in half? That's interesting. Did you all build in? They're like, we don't know. I don't know. If there are some folks who are older, I've heard them say, I remember when I was a little girl And some folks came to my parents' apartment or house, and the next thing we know, we're told to leave, right? We had to move. And what do they see a few months later? Boop, their homes are gone, and they start building the 41,000-mile interstate highway. Again, from the Truman administration, we saw the development of this, but it was implemented with state and local governments having that collaborative power. And of course, they chose to place these in communities that had the least privilege and power in society. Surprise, surprise. Today, we know that this, as well as others, the Housing Act, which displaced over 500,000 African Americans, Latinos, and Asian Americans in a community of poor whites, that that law actually also led to taking their homes, then selling the land to property appraisers very cheaply, which then created that for more affluent communities. Again, we see the health impacts it's had over time. Well, if you look at even in major cities across the country, New York, Chicago, St. Louis, et cetera, is it any wonder that the majority of bus depots are usually placed in communities of color? Isn't that interesting? And we wonder why these kids are growing up and having the highest rates of asthma, can barely breathe. They're breathing in the most polluted air in society. We see, and it's not surprising, these redlined communities that we just talked about have the highest rates of maternal mortality, highest rates of diabetes and cancer and heart disease in the country. Again, intentionally designed. Well, to make a long story short, today we can see the effects that these policies have had on these communities in the form of a property tax, paying higher payments for auto insurance, home mortgage loans, getting lower property appraisals as a result. You see the compounding effect, right? Both in terms of public policy, big P policy, governmental policy, and private policies, right? Non-governmental policies. It's also interesting where the commercial interests working hand in hand with the political actors said, well, if the governments, local, state, federal, aren't going to invest in these communities, why would we invest in these communities? That would be a poor return on our investment, they argue. And are we surprised in that we see food, hospital, pharmacy deserts in these communities, making it more difficult for these folks to access resources to improve and maintain their health? And then we also see today the impact of climate change. You heard me mention I couldn't get here last week because there was a major storm and it canceled my flight, created flooding. Well, we know that climate change is having significant health impacts across the board. I highlight, in this case, climate gentrification that's happening. I was just in Mississippi yesterday, and we had a number of folks from Louisiana at this event. We're talking about the water crisis in Jackson, Mississippi, and folks in Louisiana were saying, my gosh, did you see that new study that came out about the Native American community, the first that's recognized as in terms of a population group that is impacted, that had to be relocated now because the water levels are rising, the storms are intensifying. Well, interestingly enough, as we look at these communities by the seashore, many times these state and local laws prevented African Americans from owning land by the seashore or other population groups. They were forced, ironically, further inland onto higher elevated lands. But as the sea levels are rising, as the storms are intensifying, these folks are moving away from the seashore and they are displacing, again, hundreds of thousands of Black and Brown individuals, and it is having significant health impacts. Something to think about as you move forward in your careers. So all told, we can see the impact that these political determinants have on various communities across the United States. Professor Michael Marmot, who's been a trailblazer in the social determinants of health movement, has stated over and over again that life expectancy as a measure of health tell us a great deal about how we are doing as a society. And the inequalities, though, in that society tell us even more. Where you live, as we've all heard, absolutely matters. It sure does. And as you can see on this screen, the neighborhoods that were redlined, that were starved of resources by acts of law and policy, are now today the very communities that have the lowest life expectancies and the worst health outcomes. Notice the generation that is lost depending on where you live, right? Well, We know policy has been a driving force, as we've been talking about, driving force for many of these health challenges, public health issues that we are dealing with. Perhaps we have seen or experienced ourselves, but I believe that policy can be a driving force for helping us, achieve health equity in the long run, because only policy can fix what policy has created in the first place. So give me one more chance to bring you back in the past. Promise this is the last time. I want to take us back to a period, 1789, because I've had folks who have challenged me and said, Daniel, why are you starting at 1641? That's not even fair. We weren't even a constitutional republic then, right? So what are you talking about? And I said, all right, fine, let's start at 1789. Let's start there. And I want to start there because William Faulkner says, the great Southern writer, that the past is never dead. It's not even past. And how true is that as we've gone through the last 3 years? So in 1789, there was a group of mental health reformers, abolitionists, advocates for homeless populations, and other marginalized groups that got together and said, you know what? We need to get our federal government, we need to get them to provide for the general welfare of the people residing in our borders. And as they thought and strategized, they said, well, we need a major policy influencer, right? Alone, we probably won't get anywhere, but we need someone who's going to really push that agenda forward and get the federal government to do right by our most vulnerable people. So they recruited Benjamin Franklin. And although Benjamin Franklin had been a lifelong slave owner, it's amazing as folks age and get close to their deaths, how quickly they say, I have been wrong. And I want to actually do right before I take my last breath. And that's what he did. So he says, sure, I will lend my name to this petition, oh, health equity champions that you are creating. And in the petition, they called for the federal government to stop the separation of children from their mothers, to stop the breakup of enslaved families, to abolish that institution once and for all. They also, in that petition, pleaded with the federal government to also provide for the necessities that these vulnerable groups needed, to provide food and adequate clothing and provide shelter and perhaps education, healthcare services, and even true employment opportunities. Well, if you think we're having a very contentious debate over health equity, health reform, and the like, it seems to me that it was equally, if not more contentious back then. Folks in the House and the Senate said, how dare you, Benjamin Franklin? How dare you, health equity champions, bring up this issue when you know that we're just getting settled as a federal government? Now is not the time to address these issues, he argued, or they argued. And the Senate said, you know what? We're not even going to dignify this petition with a response. We're going to ignore him. How dare you, Benjamin? But the House said, we can't let Benjamin and these health equity champions get away with it. And so, in bullet by bullet, they made an argument, a confederalism argument, essentially punting the responsibilities to the states, arguing that it is not the role of the federal government to provide for the general welfare of the people. The states, which are closer to these people, know what's in the best interests of these people. Therefore, they should be the ones leading this effort. And that's something we hear that time and time again, right? Well, by the time that petition got to Benjamin Franklin, he died. He had passed away, and that was the first time in US history that the light of health equity in public policy had dimmed for health equity champions. It would take us 75 years later for the stars to align under the presidency of Abraham Lincoln during, of course, the Civil War. It takes that crisis to get us to really move the needle of health equity forward, unfortunately. And during that war, they negotiated in 1863 for 2 years. They were constantly negotiating for the same things that those in 1789 had advocated for. How do we provide the necessities to these newly freed people and poor whites who are going to be displaced as a result of the Civil War? How do we ensure that they have access to education and healthcare and true employment and even security that they're going to need from their former slave masters? How do we do that? And so they developed the Freedmen's Bureau Act. They started working on the Freedmen's Bureau to ensure that this would be a all-encompassing, right? And a comprehensive program to provide and address the social determinants of health needs, if you will, for poor whites and African Americans at the time. And they went about negotiating until we were winding down the war. And President Lincoln says, my goodness, enough is enough. I need you all to pass a bill, get it done now, send it to my desk, and I will sign it into law. But there was one provision that just kept dragging out negotiations. How many remember what that provision was? Anybody remember from the Political Determinants of Health book? Anybody remember? No. It was the provision to grant healthcare services to these population groups. That was the provision that was so contentious. Not the education, not the employment, not even security. It was the provision of healthcare services. And so in the spirit of compromise, the president said, just strike it and get it passed, send it to my desk, let me sign it. He did that. It's signed into law. What happens in history? 4 weeks after he signed it, what happens? He was assassinated, right? He's assassinated. And his opponents, not wanting to squander the opportunity that crisis presented, said, wait a second, you know what? Upon rereading this bill, we believe that it actually authorizes us to provide health services to newly freed people and poor whites across the country. And so they went about, through their interpretation, recruiting clinicians from the North into the South. They started working on actually building sanitariums and clinics and hospitals across the South and the Midwest. And it started having a pretty significant impact. In fact, from the data, about 500,000 African Americans alone were benefiting from the Freedmen's Bureau Act, and countless whites were benefiting from this. But as we have seen over the last 3 years especially, hate never takes a break in this country, and racism doesn't sleep. And that's exactly what happened, where opponents of health equity worked tooth and nail to really gut that program and dismantle it. 7 years afterwards, they succeeded in 1872. And then we know that it would take basically 150 years after that before the political stars would align under the presidency of Barack Obama, and we would have another attempt at comprehensive and reticulated health reform, the Affordable Care Act. A law, a policy basically that for almost 2 years, from the 2008 elections and pushing both Barack and Hillary and John McCain to ensure that they were going to prioritize health reform, to ensuring also that they would embed a robust health equity agenda in their policy proposals. It took us 2 years to fight to get that agenda included and, of course, maintained in the bills. But thankfully, for the first time ever, we were allowed as community leaders and so forth to be a part of developing that bill, which has very unique lenses to it, right? We brought together racial and ethnic minorities, we had white folks, we had older adults, women's groups, civil rights groups, you had the children's advocacy groups, the veterans groups, a very diverse group that had never before collaborated in this manner on a health policy, coming together under the umbrella and under the North Star of health policy or health equity to make sure this health policy was inclusive and equitable. And today we have 62 provisions in that law that have been pressing and pushing forth the needle of health equity. Something to think about. Very, very exciting news there. Well, let's talk about how we can leverage the political determinants of health. We've seen and we've been talking about how the hierarchy of human value has evolved over time, over the last 400 plus years in this country. But before any of you say, my gosh, this man came in, he's so depressing, right? It's first you're talking about 75 years before you got a bill, and then it was dismantled, then it took another 150 years. Well, here's the really good news. We have witnessed the incredible impact that equity-focused or egalitarian policies have had in this country and across the world in other countries, right? Such as the Civil Rights Act, the Voting Rights Act, the Fair Housing Act immediately following their passage, their implementation and enforcement. And in fact, in one study that was done by Nancy Krieger at the Harvard T.H. Chan School of Public Health, she, along with her colleagues, were examining the 1960 Civil Rights Act on infant mortality rates. And what the authors found was that the concurrence of the timing, the abruptness of the rate changes following 1964, the sharp decline in death from infant conditions treatable in hospital settings, and the contrast with minimal changes among whites suggests that the Civil Rights Act of 1964 was the cause of these trends. The researchers estimate that between 1965 and 2002, approximately 38,600 Black infant deaths were prevented because of Title VI of the Civil Rights Act. Isn't that amazing? 1965 to 2002, 38,600 Black infant deaths. And what we also saw, a trend that we've also seen because of these policies, after passage of Voting Rights Act, the Medicaid and Medicare legislation, and fair housing and so forth, we then saw declines in the premature deaths of racial and ethnic minorities in the United States across the board. But then what happens? We get into the early 1980s, and we start seeing an increase in premature deaths among these groups and a widening of the life expectancy gaps between population groups after attempts to limit implementation of those equity-focused or egalitarian policies. Think about that for a moment, right? Think about that. What happened in the 1980s? An effort to constrict, an effort to pull back, claw back funding for many of these programs. Surprise, surprise. Well, let's move on. In our country, we have talked about how the principal roots of current and historical health inequities are found in the political determinants of health, which inequitably distribute social, medical, healthcare, and other determinants. And they've created the structural barriers to equity for population groups who lack power and privilege. All political determinants affect every single person on this earth because they encompass the systematic process of structuring relationships, distributing resources, and of course, administering power. However, there are stark differences in how negatively or positively they affect certain individuals and communities. So I wanted to use this as an example today. As you all think about transportation as a major social determinant of health, and many of you perhaps will work for a major healthcare entity or an insurance company. And so I hope this resonates a little bit. You know, think about when a transportation policy, right, through a transportation authority, removes a bus route that runs through a community with residents who heavily rely upon affordable public transportation to get to their healthcare appointments, to get to their jobs, to get to school. The individuals and the families living in that community suffer from a negative political determinant that creates an inequitable resource distribution of public transportation services. Now, we've all heard and seen and read about the forward-thinking healthcare organizations that have launched programs to pay for taxis or ride shares for folks to get to their healthcare appointments. But think about this. Those efforts, while they're effective in their immediacy, really aren't tackling the root causes of the inequities facing their patients. Because when such an affected community, though, comes together to advocate for themselves, gaining momentum by, of course, convincing more individuals, by convincing leaders such as yourselves, right, and businesses in town and others to join their effort. And when they succeed in getting their bus route reinstated, and they also have enhanced opportunities to not only access it, but utilize it, they have understood the chance to restructure their relationship with the transportation authority and ensure more equitable distribution of resources by this government entity. They will have essentially exercised the power inherent in understanding and addressing the political determinants of health. Now, let's talk about how we actually can utilize this. Let's break it down a little bit better, right? We've looked at this tripartite definition. We've talked about redlining, how that led to structuring relationships. We didn't talk about the anti-miscegenation laws. Obviously, I come from the state with the most anti-miscegenation laws, Nebraska, of course, wanting to forbid Black and white and Asian and Native Americans from mixing. It's quite interesting, but you can see how laws have been developed over time to structure relationships in our country and across the world. You've seen how they've been utilized to distribute resources, right? Depending on the jurisdiction. And we've seen also time and time again, my God, every single day I open up my phone as I wake up and there's a news item showing how people are trying to usurp power, whether between local and county governments or between the state and the city government, the municipal government, et cetera. So I want to look at how we can leverage political determinants of health to improve the structural conditions in which you and your communities find themselves in. So whenever I'm analyzing a health outcome, whether it is an inequity or not, I think about them in terms of how they came to be in the first place. What was the policy that created or has been perpetuating or exacerbating that problem? How did the policy or political action or inaction structure relationships in the community? That's one. How have health protective and health sustaining resources been distributed in the community, right? And then how has power been administered? How has it been shared? How has it been, given in that community? And then once that analysis is done, I then create an action plan focused on the political determinants of health framework. So this is the framework. This is looking at evidence from the political science field, looking at legal, historical, public health frameworks, right? And looking at what, in terms of levers that have been pushed and pulled over time to advance or hinder health equity, what that has really looked like in the country. What have they done? How have they used it? And so very quickly here, for the sake of time, the idea here is that once a perceived inequity is identified, you have to conduct your due diligence to ascertain whether the health outcome is systemic. Is it avoidable? And is it unjust? How far can you venture to understand whether it is an institutional or structural barrier that created or has been perpetuating that inequity over time? What is the policy change desired? And can you demonstrate the value of investing in change? That is absolutely critical, because in the United States, as well as in other countries around the world, we as advocates have to understand the disquieting and the harsh truth that the political determinants of health inequities have rarely been addressed unless their reduction or elimination served other purposes. Think about that for a moment, right? The success of any advocacy effort has depended on how palatable they are to commercial interests and whether there is an investment value to the government. And that is true of many levels of government. Think about that. So I wanted to use this as an example when I'm talking about how this has worked. As we were working on the Affordable Care Act, as we were mobilizing to infuse that robust health equity agenda to ensure that the policy would do no harm to any population group, but would actually benefit all population groups, we were looking back in history when the Obama administration said to us, Daniel, yeah, we're going to be changing a few things in terms of the focus of health reform. So remember, I don't know if you all remember this from the book, they went from calling health reform comprehensive health reform, right? And we all latched on that, and we got the Obama campaign to explicitly mention that as part of that priority, eliminating health disparities would be one of them, right? But when we got to the transition in government, as we're meeting during that transition phase with folks, a lot of Obama's senior advisors were getting nervous. Ooh, well, we'll do that separately. We'll handle that issue in another bill. And we said, no, you're not. You're going to handle it in health reform, because if you are going to call this comprehensive health reform, if you truly are going to address the fragmentation in healthcare and address the most pressing issues, well, then it starts with including an equity lens to the development of the entire law. But what happens? We go from comprehensive, they chopped off comprehensive, it's now just health reform. The Tea Party is heating up, and folks were getting nervous again in the White House. And so we even dropped, we now go from health reform to it's health insurance reform. Let's narrowly tailor the focus, because again, who likes the insurance companies? They've been discriminating against folks for years. People are having, a challenge, a difficult time trying to access healthcare in this country. So they thought that was a smart strategy. And of course, we were like, yeah, that's smart. Okay, yes, let's call it health insurance reform. We agree with that. Why not? But that backfired on us, because then all of a sudden, I remember this night, it's like 11 o'clock at night, we get a call from the White House saying, oh, yeah, we had to make some changes. We're going to have to delete or remove some of the provisions that you all have been fighting for. We said, yeah, we get it. We know it's compromise, as your negotiating policy. We understand. What happens the next morning? We see in the New York Times on the front page, this article that was quoting senior advisors saying that, oh, yeah, we're going to have to get rid of the data collection and reporting provisions. And if you all remember from the book, the data collection and reporting provision was the #1 policy priority for our national working group on health disparities and health reform. We recognize that there is no data, then there is no what? No problem, right? There is no problem. So we keep on ignoring the truth and hiding. So we said, nope, that's not going to work. Then there was another quote about getting rid of the school-based healthcare center funding and provisions to elevate access to healthcare for children in our schools. And we said, what? And then something for the community health centers, again, wanting to strike the funding for that. I said, absolutely not. And there were a host of other provisions. So we said, nope. And we worked with our champions in Congress. President Obama himself, I think, was quite surprised to hear this. And he was called forth by the Tri-Caucus, the Congressional Black Caucus, the Hispanic Caucus, and the Asian Pacific American Caucus, to respond to this article. They were extremely upset to hear this. The president himself was surprised. And he said, I will make sure that that is corrected. No, health equity is going to be. We said, great. Well, things start heating up again with the Tea Party movement. And many of you, I'm sure you're old enough to remember the negotiations and the intense opposition against the law, where opponents of health reform were outspending us 7-1 during negotiations, and then afterwards 15-1, right? More than double the opposition to vilify the Affordable Care Act and to put it in a false light. So the administration said, you know what, we're going to have to change course a little bit. And you all need to justify. We're just going to put provisions in this bill that will actually reduce, that will bend the cost curve in healthcare. And we said, all right, well, we believe that it will bend the cost curve, right? You address inequities, going to lead to such. They're like, no, y'all need to show us how it's going to be done. And taking a lesson out of the book of our mental health reformers in 1946, who had, my goodness, right, for years, Dorothea Dix had dedicated her life as a school teacher from Massachusetts to going around the country highlighting the abuses against people with mental illnesses, right? Documenting this, finally convincing Congress, both Democrats and Republicans, to do right by these people. They get the bill out, the bill for the benefit of the indigent insane, only to have President Franklin Pierce, who's considered one of the least effective presidents in our nation's history, veto it. And they thought surely this was going to be the first president in American history who understood the impact that mental illness has on the individual, on the community, on the family unit, right? He had witnessed a tragic incident, having seen his wife decline from depression and anxiety for the rest of her life, right? After a train accident where their firstborn child died tragically, the only one in this new invention called the train. And his head had split open. There was skull fragments. It was horrible from the records. And he himself became a substance misuser, became an alcoholic, right? Kept drinking away his problems. And instead of understanding how impactful this bill would have been for people who are similarly situated, he instead vetoed it and set the federal policy of inaction in these mental health welfare issues, if you will, for the next almost 100 years. It would take this country now, going through the Civil War, World War I, World War II, bringing the nation on its knees in terms of mental health, for the country to say, oh my God, now we see the effects that mental illness can play on our systemic health. We can see the impact it is having on the economy, and we can see the national security impact it is having. So they worked, these mental health reformers worked with our government, they worked with military leaders, admirals, generals, they worked with the Surgeon General, ironically, the same Dr. Perrin that I mentioned, and the business community to develop a policy to address mental health, or at least it was a piecemeal approach to at least research mental illness in this country to understand it better. And so in doing that, the way they were able to get that done was they developed a study that showed 20% of young people at the time were unfit to serve in the military, right? 40% of these young people in 1946 ended up leaving the military owing to PTSD. And then 60% of the hospital beds were being occupied by people with mental illness. Now they recognize, oh my gosh, this does have serious health implications and economic and national security implications. And that's how they finally got the country. When you're looking at the hierarchy of value that we place on different chronic diseases, finally elevating mental and behavioral health, right? Enough to at least get the policy done. So taking that lesson in 2009, we worked with leaders, retired admirals and generals, and of course, academic scholars to do another economic study, looking at what the toll was. So you heard me talk about Levis and others with the racial and ethnic cost burden. And with these retired admirals and generals, we wanted to know what was happening though from a youth standpoint. 17 to 24, modeled after the study that was done in the 1940s. And what we found was that it had significantly increased from 20% unfit to serve in the military in 1946 to, how many remember what the amount was now in 2009? Anybody remember that figure? How worse had it gotten? Nobody remembers that? 75%. 75% of young people were unfit now to serve in the military in 2009, owing to obesity, higher criminalization records, mental illnesses, and the list goes on. 75%. So now we had these two studies that we were able to use to say, oh, White House, oh, Congress, hello, you can't ignore the inevitable. It is going to get worse before it gets better. And as we become a more racially pluralistic society, whether you care about these population groups or not, here is how it is going to impact you economically and security-wise. And that's when we were allowed to stay at the table and continue driving that health equity agenda in health reform. Interestingly, when you look at the framework, right, the moral argument alone has always been insufficient to drive policy changes. You have always had to tie it to that economic, these are health equity focused policies especially, to an economic and national security argument. Those that actually understood that, when you go back in the course of time throughout our history, those are the ones who were successful in getting these egalitarian policies advanced. So where do we go from here? You know, we've looked at the fundamental causes of health inequities in this country, how the political determinants of health inequities have given racism a helping hand in driving many of these conditions that we find ourselves in. But here is what we need now more than ever. As you think about your role, as you think about leveraging your education, as the next generation of public health scholars and leaders, I hope you'll remember this. This is from my dear friend and mentor, as I mentioned, David Satcher, who served as the 16th Surgeon General of the United States and Assistant Secretary, someone who dedicated his life to fighting racism in public health and healthcare, a man who was bold enough to address the underrated, highly stigmatized issues that nobody wanted to touch in the past, right? But he knew if we were going to advance health equity, we absolutely had to. And he says to me, now more than ever, Daniel, what we need are scholars, leaders, public health professionals who care enough, know enough, have the courage to do enough, and who will persevere until the job is done. First, you have to care about these communities. You got to care about them, right? But caring is simply not enough, as you have heard today. You also have to avail yourselves of the political determinants that have instigated these inequities, right? These divisions in our society. And you have also heard today that this movement to advance health equity is not for the faint of heart. It takes tremendous courage and perseverance, because it can get quite upsetting, right? When you think about how long it has taken us to even reach where we are. But it does take tremendous perseverance to get the job done, to achieve health equity. And I hope that as you continue in your education, as you continue on your journey in public health, that you will always remember these words, that you will seal them in your minds, and that you will use your brilliance, the gift of yourselves, to advance the cause. I want to thank you all again. Thank you so much, Addie, for the invitation, of course, to the chair of the department and to all of you for coming out and listening to these remarks. I appreciate the privilege of your time.